are very excited today, very excited for our presentation this morning. Um, the descriptive history and evidence of effectiveness of the group medical visit program at UW Health. I'm very grateful to all the work folks have done uh, over the summer to sort of really take a deep dive to look at our group medical visit program. So much data that was has been collected over the years, and nothing was really done with that. And there's Sarah and Dr. Barrett have taken the lead on starting to look at all that data and see what we can learn about this. Um, Sarah Walters is a research specialist with the Department of Family Medicine and Community Health, and soon to be, I'm very confident, soon to be a medical student. Her energy is infectious, and if I was competing against her to get into medical school right now, there's no way I would be getting in there if I had to compete with her for slots. She's a talented human being and a bright spirit. And I'm very glad that she was able to work with us. And hopefully this is just the start of her working with us. Dr. Bruce Barrett is the Vice Chair of Research for the Department of Family Medicine and Community Health. He has, well, in addition to being just a fantastic human being, he's done a lot of studying and research around integrative health modalities, including the placebo or a clinician effect and the impact on a common cold, echinacea and mindfulness, both for efficacy in terms of upper respiratory infections, for pain control, and for sleep. He also was the director of the Complementary and Integrative Health Research Fellowship for a number of years. And he is now taking a deeper dive into how the actions and health habits of human beings can be beneficial, not just for the individual, but for the planet as well. So I'm very grateful to both of you for taking on this work and sharing your findings with us. So without further ado, I'll turn it over to Drs. Barrett and Sarah.
Thank you, Greta. Good morning. Sarah is going to be the main presenter of this fantastic slideshow. So settle into your seats, get ready for some great learning. And I'll do a few slides in the middle, but it's been a really fun summer. And our third partner, Isabella, is not here today because she's doing some medical student thing. But she was a key partner as well, as many of you have been. Many of you have interviewed with Sarah. So I'll hand it over to Sarah. Go ahead.
Thank you. Good morning, everyone. Thank you all for being here today. I am very excited to be here today. I love group medical visits. I love this work, so I'm excited to talk to you about it. So, further ado, Dr. Barrett and I will talk about group medical visits here at UW Health and their history and their evidence of effectiveness. So I have been working with Dr. Barrett doing research since my undergraduate years here in 2020, like Dr. Kufel said, incorporating mindfulness and ecological sustainability into wellness. So that work transitioned into helping Dr. Barrett and Beth Wartzel, who is here today, a mindfulness instructor, beginning our group medical visit called Mindful Eco Wellness. And since then, it has transitioned into this work this summer, doing work on all of the group medical visits here at UW Health. So today we will go through the history of group medical visits, learn about the various purposes, design, structures of group medical visits, and we'll go through our qualitative and quantitative evidence that we have found. Also a reminder, this is a project focusing on quality improvement rather than research, so it is exempt by the IRB. So this is our team for this past summer. We have Dr. Barrett, myself, and then the wonderful Isabella Rodriguez Cardenas. And she is an M2 student, like Bruce said. And she has been a wonderful part of the team. It has been so fun to work with these people. So we kind of had two parts of this project. My main part has been working on the evolution, the history of group medical visits, and then Isabella focusing on the evidence of effectiveness, but we have both worked on everything together with our fearless leader, Dr. Barrett. So what are group medical visits. So group medical visits, as many of you probably already know, are medical visits with 7 to 10 patients, meeting with a clinician and another provider, typically a mindfulness instructor, a chef, a health coach, a dietitian, meeting for an hour to 2 hours once a week for about 4 to 8 weeks. Each GMV is unique and can address a broad spectrum of conditions. Some are more specific than others, but it is a space where there's community with patients, clinicians, a place for patients to practice new behaviors with hands-on experience from clinicians and their providers, and create this community that really fosters a lot of growth. It's really wonderful. And so to be a part of group medical visits, patients need to have a condition that meets the criteria. For example, for Mindful Equal Wellness, the one I do with Dr. Barrett, you just have to have kind of a chronic disease ailment, but some can be more specific, like yoga for cancer. So as many of you know, chronic diseases are a significant and growing challenge here in the US. According to the CDC, there's an estimated 129 million people here with at least one major chronic disease. And as you know, these are not only reducing quality of life and increased healthcare costs, but also leading causes of death. So given the scale of this issue, there is such a need for innovative approaches to manage these conditions effectively, empowering our patients with lifestyle behaviors and providing them with the supportive care they need and deserve, while also reducing the burnout of our providers. So group medical visits have like a unique opportunity to potentially address some of these burdens. So here at the Center for Wellness, what do we address? I kind of mentioned earlier, chronic diseases, but we also address a whole bunch of other things too. So just to name a few: stress, sleep, AFib, nicotine cessation, which was an announcement earlier today. And there's a whole slew of things that we do here, which is really awesome. So when did these begin? So we began in 1999 with the Belleville Family Clinic with Dr. Melissa Stiles. She began doing a weight management GMV, and then jump forward to 2012, she began doing the healthy aging, which then transitioned to doing that here at the Center for Wellness in 2019. The next clinic to kind of jump on to GMVs was the Verona Family Medicine Clinic, doing their fitness and lifestyle challenge. So they've been doing that since 2014, took a pause due to COVID, and then restarted again in 2023. And then for the Center for Wellness in 2017, Dr. Lisa Grant, she and her team were doing consulting with patients and trying to see what the need was. So what came up was stress, what came up was chronic pain. So that's some of our first GMVs for the Center for Wellness, being stress reduction and resiliency, and healing waters, which is addressing chronic pain in a pool. And then also kitchen wisdom, which is still going on today, and it's done by the wonderful Lisa Simpson. So we've had lots of different GMVs come up through the years. For example, yoga for cancer beginning in 2020, and mindful eco wellness beginning in 2022. And then also, not surprising to anyone, in 2020, there was a stop for all GMVs across all of the facilities, and some of them transitioned online. So this is a different representation of kind of the same slide, but I really wanted to show how there's kind of 3 different facilities of where GMVs have been practiced here at UW Health. We have, again, the Belleville Clinic, Verona, and then the Center for Wellness. And then they each kind of have a couple of GMVs they're doing, and then Center for Wellness, we've been doing about 15 plus GMVs over time, and there's new ones being added all the time. So specifically at the Center for Wellness, to date, we have had 114 GMV sessions, providing care for approximately 800 patients, and this is an underestimate. This estimate is not including Verona or Belleville, so probably over 1,000, which is very neat. And what does a typical year look like for Center for Wellness? So this was our 2023 schedule. I color coordinated all of the GMVs so you can kind of see how often they occur, and it really is varies per GMV. Like for example, yoga for cancer is every season, healthy aging is once a season, And again, this is kind of showing too just the wide range of conditions that are addressed, from kitchen wisdom, mindful eating, yoga for cancer, support people going through cancer, and then the things like living with AFib and helping with things like that. So transitioning on from talking about kind of the evolution of group medical visits and their components and talking about their effectiveness. We did qualitative and quantitative effectiveness methods. So for our quantitative effectiveness, we were looking at the Promise 29 questionnaire. And then for the qualitative side of things, we conducted interviews with patients, clinicians, and other really important people that make GMVs happen, along with looking at qualitative questionnaires. So on the quantitative side of things, we looked at Promise 29s completed by patients at the start of their GMV and then at their end. And we pulled from GMVs of yoga for cancer, stress reduction and resiliency, mindful eco-wellness, and mindfulness for your health. And we conducted t-tests comparing those pre and post scores. And Dr. Barrett will talk more about the Promise 29 and our data.
Brilliant presentation, Sarah. This is great. So the Promise 29 is a health-related quality of life outcomes instrument. It was created by the Promise Group, which is led by Professor Dave Cella at the Feinberg School of Medicine at Northwestern. They got NIH funding to cull the literature and find the most important outcome instruments, and then do systematic assessment of the psychometric properties of all of the items and all of the domains that they cover. What's cool about the Promise instruments are that they are free, and that they all have been thoroughly vetted for psychometric properties, and you can go look those up and see if they're good at what they say they're measuring and how they do that. So Promise 29 measures the 7 of the most important health-related quality of life domains of physical function, sleep, anxiety, depression, social roles and functioning, pain, and fatigue. And it does so by asking people to fill out the Likert scales. And yes, it is pronounced Likert, not Likert. Professor Likert is now passed, but his daughter, I think, still living, and other descendants would. In any case, you fill out these Likert scales, and there's usually 4 items for a domain, and then those 4 items within that domain are compiled together for a domain score. Next slide. We found 100 patients who we thought filled out the Promise 29. They came from 16 different GMV cohorts from several of the different GMVs, as Sarah just showed you. Of those 100 people, only 68 had filled it out fully, both at pre-visit and then at the end of the group medical visit session, usually 4, 6, or 8 weeks later. We put in the rule that they had to have filled out at least 75% of the items. If they filled out 80 or 90% of the items and one of the items data was missing, we first assessed for whether it was missing at random, and if it satisfied that criteria, we did multiple imputation, which I can talk about separately with anybody who's interested. In any case, we were amazed to find that even with a sample size of only 68 people, which is pretty limited in research, there were statistically significant increases in all 7 health domains measured by the Promise instrument. Physical function went up, anxiety went down, depression went down, sleep disturbance went down. Pain interference. Pain interference is the degree to which pain interferes with your function and quality of life. There, the statistical p-value was only 0.03, so not as highly significant as all of the other changes. Social roles increased, which I think might be one of the key ways that group medical visits help people, because you come together in a group and communicate with other human beings who care about you and listen. So we found evidence pre compared to post in all of these domains that the group medical visits were effective. Next. I like these notched box plots. You may or may not, but let me try to explain these. If you look on the left side of your screen, you see all of the Promise 29 domains. Let's start at the top with physical function. Those boxes are all the way to the right. That shows that our participants in general were functioning pretty well. They were not limited to large degrees on average by physical function. However, some people were. So you see there's some dots there on the left. Those represent individual scores, individual people who were outside of the statistical range of the group. So they're considered outliers. The horizontal line shows the normal statistical range of that item. The width of the box, the blue box and the green box, shows the interquartile range. And in the middle of that interquartile range, there's a vertical dark line. That's the median. So half of the people scored below that score and half of the people above that score. And then the length of the box shows the interquartile range, so that a quarter of the patients are going to be on the right on average and a quarter on the left. And then the notch, the width of the notch shows the 95% confidence interval. So you can do some mental, statistical testing by just looking at these figures. So these people in general had high physical function and low pain. If you go down to the very bottom, you see the pain scores. The pain scores are significant, but they're not horrific. Similarly, the anxiety and depression across these 68 people was not super high, but impact on social roles was pretty high, and they had a fair amount of fatigue and sleep disturbance. The boxes on the right, that's from the single item that everyone's familiar with, the 10-point, how much pain do you have right now? So that's not a whole domain with multiple items, that's just the pain score. Next. You can combine the several of the domains together under the rubric of mental health or physical health, and you can get combined domain scores. But that's pretty much what our quantitative data shows. And I will hand it back to Sarah, who's going to tell you about the qualitative data.
Thanks, Dr. Barrett. So like Dr. Barrett just said, on to our qualitative data. Our qualitative data was kind of three big parts. So it was interviewing clinicians, patients, and other really important people to the GMV experience, reviewing those transcripts of those interviews, and then reviewing qualitative GMV surveys from our patients. In reviewing the transcripts, we were identifying and the surveys, identifying themes, codes, and quotes, and going through those. And I will talk more about the transcripts next in a little bit. But for interviewing, patients volunteered to interview at the end of GMV completion, and we had semi-structured interviews via WebEx. So going more in depth into our interviews, we have separate clinician and patient interviews where we try to gauge the experience and effects of GMVs on patients and providers. We've interviewed 14 clinicians so far and 6 patients, with potentially more very soon. So after Isabella and I conducted these interviews, we transcribed them, and then we had at least 3 to 4 people looking at each one, with Isabella and I looking at all of them. So we ask our reviewers to keep these 2 questions that are on the screen in mind. We ask, what are the major components and learnings involved with the UW Health GMV experience? And then we also ask, what do patients, clinicians, and other health personnel say about the potential benefits of GMVs? So before going into review sessions, we think about these questions and then discuss themes, quotes, components, and other things that kind of, with these 2 questions really being our guide. So what did we find? We found a lot of really wonderful things. The first being patient autonomy and empowerment. So this is describing the patient education and promoting agency for patients to make informed decisions about their health, GMVs provide a really cool space where they can really practice and learn behaviors hands-on. So that wasn't really surprising to us. And then going into that sense of community, where these patients are with people who have also experienced similar things. So there is a lot of growth in community. There's camaraderie and trust among patients and clinicians that is built over the GMVs. We've seen reduction of loneliness. This has been described with from both clinicians and patients. And a special part going kind of into clinician satisfaction, the next one, clinicians also feel the same sense of community within their patients, learning and growing with their patients too, which is really neat and goes into how clinician satisfaction has been something that every single clinician I've talked to has touched on, how GMVs have brought in joy into their work and helped reduce burnout and provided a space where clinicians can be creative, incorporating different aspects into their care. And that kind of goes into our next major theme of integrative care. Well, we're not bringing clinicians, we're also bringing different healthcare providers like chefs, mindfulness instructors, health coaches. So we're bringing a whole team of people, new skills, different skills being able to apply, and really doing a more holistic part of care. And then lastly, trust. The really neat thing about GMVs is they're for many weeks. So we're building relationships. Many clinicians have talked about being able to see their patients in a different light because they get to have these longitudinal week by week relationships and seeing them grow week to week, which is really wonderful. So some quotes that kind of go along with some of our themes. This quote right here is a two-parter. So first, this clinician is talking about how the relationship with patients have been able to be more deep. So saying, thinking about the whole person holistically, what are the different things in their life, bringing in different aspects of that. And then this clinician talks about what they can bring to the GMV experience and saying, bringing other mindfulness, mind-body techniques that I've learned from mindfulness meditation, yoga, and other things. So really touching on just some more tools that clinicians can bring to this space. The next quote, I love this quote, and it goes, we're really good at fixing broken pieces, broken bodies, but there's so much more we could offer to help people to be healthy and whole, and not just to give them information, but like, let's show them how to do this. Well, I think it's empowering for patients, but it was empowering, I think, for me to do it too. Really cool talking about the patients being empowered, but also the clinicians being empowered as well. And then the last quote from one of our clinicians saying, I feel like being able to do a GMV is a really positive thing for creativity. I think it's really important that we have creativity, a chance to learn and practice in ways that are really kind of dynamic. So in conjunction with the themes coming from mainly providers and patients, what are some learnings and components? So some learnings we have found is in recruitment and access to patients. Recruitment. So some clinicians have had no problem filling their GMVs, but some GMVs have had a hard time filling. So that has been a place where maybe some more improvement is been called for. I think the hard part is getting patients to know about this resource of GMVs. Another thing is access to patients. In order to do a GMV, you have to do activities of daily life. You have to be at Research Park or East Madison Hospital at a certain time of day for multiple weeks in a row. So access can become a barrier there. Another theme we saw was insurance. A lot of GMVs can be covered by insurance, but there's often a copay. And then we see themes of support. So learning from interviews, it takes a lot to get these GMVs rolling on the side of clinicians. So there's been a call of support there. And then also even just learning how to facilitate a group and getting the guidance of how to do that, because it's very different from going one-on-one with patients. Another aspect of support is support for our patients after GMVs. We give them multiple sessions where we're learning these new behaviors, and giving them hands-on practice. And so what do we do after? There's been ideas of doing drop-ins. Often some patients have formed their own walking groups that have continued after GMVs. Lisa Simpson used to do a follow-up class once a month after Kitchen Wisdom, providing a space for patients who have already completed Kitchen Wisdom. But there is more growth and learning for there. But overall, GMVs are a very unique form of healthcare where there's longer, more in-depth connection of clinicians to patients and patients to each other to help empower, heal, and grow in a community of support that can enrich both patients and providers to be teachers and the students. So the future of GMVs moving forward, we have done over 100 GMVs here at UW Health over the past quarter century. GMVs fill a crucial gap in healthcare and are well liked by both patients and clinicians. Both of our qualitative and quantitative evidence suggests that GMVs may be effective. Oh no. And more than 800 patients have benefited from GMVs. So as we move forward, GMVs can help make healthcare a space not just for treatment, but for community and holistic well-being and empowerment. I'd like to end with a quote from one of our patients saying, "I hope they have the time and resources to add more and for more people to benefit, because I think it was a really effective, fantastic class." So lastly, I'd like to thank everyone who's made this happen: Alyssa, Diane, Caitlin, Karina, Dr. Kufel, Lisa Grant, Lisa Simpson, Beth Wartzler, who I saw today, Isabella, Dr. Barrett, everybody. Thank you to all the clinicians, health coaches, mindfulness instructors, and patients who are willing to do interviews and help piece this together. Thank you, and any questions?
Thank you, Sarah. Wonderful presentation. It's really great to see all that data kind of put together. I'm wondering if folks have questions. You can feel free to raise your hand, but also, there's a lot of people in our meeting this morning that have participated in or have led group medical visits. And I'm wondering if you have any comments or things you'd like to add about the experience or things that you've noticed in your own work with group medical visits.
Oh, I'd also like to add that Isabella and I are each writing papers about this as well. So we're still in the progress of finishing those. So if anyone has anything they'd like to share with us, please feel free to reach out.
I think I'm sorry, I think we need to acknowledge the SSRCA program too, which supported Isabella throughout this summer. This has been a really fun summer, and I want to thank everybody who's been so kind and generous working with Isabella and Sarah on this project. I fell in love with GMVs 5 years ago, or 3 years ago. It's been really wonderful. Beth and I have worked. I see Beth's face there. It's been good. So we are biased. That this is as we go to try to publish these results, we need to be very careful because we believe this stuff works. The evidence that I showed you, while statistically significant, there are no randomized controls. We might be showing not only our biases, but our patients' biases who will say nice things about us because we were nice to them. Yes. So this is the evidence that we have here is very preliminary, and I would like to see some, much larger, better, higher quality studies. I better shut up or I'll just keep talking and use the whole time. So.
I could add one piece just because my background is primarily in mental health. And one of the strengths of GMVs to me was the ability to bridge what is often very divided in the medical field of mental health and physical health. It was so powerful to me to have a setting where we weren't dicing those into segments, letting it all be a holistic experience.
Thank you, Beth. Kate has the question up. She was reminded of the importance of peer support for managing chronic health conditions. And have you considered the GMV within the framework of peer support?
Oh, yes. I should have gone into that a little deeper. That has been a huge component as well. We've seen, I think, patients and clinicians talk about how other patients can support each other because they'll be like, yes, I've been through that too, or just validating their experiences and being there for them. So that is a huge part. So thank you, Kate.
I'm wondering, and this question both for Sarah and Bruce, but also maybe Lisa or some of the other folks that have led group medical visits. What are there best practices or things that you found, like balances of the content of group medical visits that might work a little bit better than others? And if folks are thinking about starting one, I don't know if you have Best practice is about structure.
Speak to that. If
Yeah.
First, I just want to thank Bruce and Sarah and Isabella for that presentation. That was amazing. And just to compile all that information, I know how much information was sitting out there. So for you guys to put all that together, and it was just so nice to work with Sarah and Isabella. I feel like the future of healthcare is so in such good hands every time I meet with them or work with them. So thank you so very much. What I found as far as best practices, at least for me, for the structure, is the amount that I talk about or give information has gotten shorter and shorter and shorter. So I think probably the talk that I do during a GMV is 10 to 15 minutes out of 2 hours. And the rest of the time is sharing with participants, kind of structured sharing with certain prompted questions, and then experiential learning through the ones I teach, mindfulness practices or cooking in the learning kitchen. And then the other thing that I've really worked on, because the time can go by very quickly, is making sure to utilize the support staff that I have. So I really try to carve out at least 20 minutes, 15 to 20 minutes at the end for the health coaches so that they can play a really active role, and then have them do pieces throughout the GMB as well. And that's been really helpful. And the patients enjoy hearing from them too. And they have such a different perspective than how I was trained as a medical person. So I learn a lot from them.
I think, having that structure to me feels like it would take a lot of pressure off, the clinician that's in the room, but also sometimes when we take a step back, the wisdom it's a little bit more rich, right? There's the ownership of the wisdom of the group rather than sort of being pointed to one person. Thank you, Lisa. Shelley, you had a question?
Yeah, thanks, Greta, and thanks, Sarah and Bruce. I have a couple of questions, actually. I was wondering what your thoughts are, since I think most folks don't really sort themselves by healthcare system or the doctor they see. What are strategies you've considered to host group medical visits out in the community that maybe transcend the healthcare provider they're seeing? So, are there partnerships that we could explore or that you've explored, thinking about like the Dane County Health Council or other entities like that?
Absolutely. So my vision here is that we will have a healthy society in 50 years. Might take longer than that. And in that healthy society, we will have community centers. We will be doing mindful eco-wellness or kitchen wisdom at a community center in Madison or at a park, or that these things will be built into the schools. They'll be built into workplaces. You'll have some group health activities where you work, where you learn, in religious institutions. So group medical visits are paid for by health insurance, right? We have a broken health system, and this is one way to do these things, and it's a way we can make work. But in the long run, we need to figure out how to do health activities everywhere.
And
And I
so
think
have you all, I love that, Bruce. Have you all considered if we could pilot anything that transcends that?
Well, Shelley, that's part of in starting to work with the community health workers through the Office of Community Health, thinking about how could those types of activities be co-facilitated by community health workers. The question is, payment, right? And that's always the big barrier. But these same types of concepts, the same type of group learning and experiential learning could happen in using community health workers as guides to how does it work best in that community. So that's sort of the direction of the work we'd love to go. Does it need to be documented? Could insurance pay for it even in those settings? Are there other reimbursement ways to fund it so it's sustainable? Those are big questions, but I think we could figure it out. In the chat from Aaron, this was amazing. Thank you all so much. As a pediatrician, I've been thinking about group medical visits as a way to build parental communities in a wellness-based model rather than an illness-based model. Wondering if anyone has experience they're willing to share about recruitment and retention for families with high social needs. Mala, are you on?
I am on,
Do you
yes.
wanna, do you want to speak to the pediatrics lens and things coming up?
Yeah, so that is such a great question. And actually, I've been really interested in developing group medical visits initially for parents, but it's a little bit tricky, I think, from what I understand with group medical visits because it's paid for with health insurance. There does need to be some billing and coding considerations. And so you really need to, if you're a provider billing for a group medical visit for parents, you really have to be careful with where they're coding to make sure that insurance will cover that. So I actually did do with Lisa Thomas Prince, if she's on, we did try to pilot in anticipation of potentially creating a GMV related to mindful parenting. We created some parenting retreats over COVID that were virtual, that were through the UW mindfulness program. And we had some participation, a handful of people with each of those classes, which actually worked out really well. They were virtual because they were during the pandemic. But just to speak to your specific question, I have not had any experience with that kind of GME, but of course, I think that there's a lot of potential for wonderful expansion, and that seems like a great area to go into. I am in the process of developing a GMV here at UW with some of these wonderful people on the call, and Lisa Simpson and Alyssa have been really integral in helping me plan for this for children. So this will be an area that we're going to hopefully expand in the future for GMVs at UW for preteens with anxiety. So. But great questions, and hopefully we can stay connected, Erin, and try to figure all this out together.
I think also, part of the goal of the Osher Center is to make integrative care, like group medical visits with these foci, accessible to all and not just a subset of human beings. And I think when your question around families with high social needs, I think they have to be involved in the structure and how would this work best. And so getting patient input and understanding, is virtual better than in person? Do access to technology that would be required, all of those things. But if we include patients in the planning or, in community work, including community health workers in the planning, I think we'd have a more rich and relevant and impactful product. I'm sort of curious if Beth spoke a bit. Any other folks on the call that have been that are not physicians or physician assistant that have helped to co-lead group medical visits, and any observations that you've noticed? Maybe Lisa Thomas Prince, calling a little bit on you. Your observations of what happens in a group setting over the course, over the different sessions.
Sure. I've been fortunate to co-lead some of the Mindfulness for Your Health GMVs with Dr. Vinny Minichiello. It's been a real wonderful experience to see those groups and also to kind of juxtapose the GMVs with our mindfulness-based group classes. There's been a little bit of overlap. There have been some folks in the GMVs who had previously taken MBSR classes. And then on the flip side, there are some folks in the GMVs who are very, very new to mindfulness. And this is sort of a doorway in. And at the end of the GMV session, they're interested in maybe taking an MBSR class or doing some other mindfulness-based programming. So I think it's nice in that they can sort of the programs fertilize each other in both directions. The group format has just from what I've witnessed has been so powerful. And I shared one story with some of our Osher Center leadership team over the summer of some really important learnings that one of the participants in a recent GMV was able to verbalize at the end of the session. And the learning didn't come from Vinny or from me. It came from what one of her co-participants had shared. And the participant came back to say to her, like, fellow group mate sitting in the circle, she said, "What you shared last week saved my life." So the power is amazing over the course of these weeks together. I think it's been really impactful to see also people saying, and folks coming who I don't see often in some of our mindfulness group programs, people of color and other folks who haven't been part of our groups in the past, coming into the circle and saying, "I always thought I was the only one who dealt with whatever it was, this level of anxiety or this much difficulty functioning in my life." And hearing somebody say, "I never knew there are other people dealing with this." So that's been, those are two examples of some of the real power of the format. I do have a question, and it's maybe for some of the folks, I don't know, Dr. Barrett, if you've taken part in the conferences. I know Lisa Simpson, I think you attended some of the conferences like nationally for folks doing group medical visits at other centers. So I know there's, this conversation is happening at a lot of different healthcare facilities around. I'm wondering what the conversations are that are happening within insurers. Have they been part of those conferences? Are they hearing about the research about the efficacy of GMVs, and what are they saying from the insurance standpoint? And maybe that's not a fair question to pose to you, but wondered.
I do not know what the insurance folks are saying, and I have to say that the evidence is still fairly preliminary. There are some randomized trials out there showing that GMVs help with numeric lab values in diabetes, for instance. But overall, the evidence isn't super. It's all pointing in the same direction, but it's not like confirmatory. But Lisa, you actually are involved with a national organization looking at GMV stuff. Can you say something about that?
I'm not really necessarily involved with the organization, but Jeff Geller, Dr. Geller is one of the people who spearheads it's called ICGMV, Integrated Center for Group Medical Visits. So I took a 4-week course with him on how to set them up, troubleshooting and facilitation, and that was really helpful. And if any of you are interested in learning more about that, the annual meeting is actually Friday, September 13th, so next Friday. And you can just go to the ICGMV website to enroll. And I've been getting multiple emails saying, and it's virtual, multiple emails saying, if anyone wants to join, there's scholarship funds. I think I think it's their 3rd or 4th annuals. They're really trying to build it up. So I think if you looked on their website or reached out to them, you could probably participate for a reduced fee. So I'm going to participate in that on Friday. And also their website is great with a lot of links to ways to start a GMV, support. I don't know if they have specifics around insurance. They talked a little bit about that in the 4-week thing that I did, but not a lot. So if any of you are interested in learning more, Friday the 13th is the annual conference. You can still register.
I can throw in that this is a rapidly growing area. I just reviewed a paper that I think is going to be accepted and published soon that describes the experience of like 7 different medical centers all over the United States with just one type of group medical, with forest bathing, with nature immersion. And they're describing how it's going. The forces are in alignment, and one of the big forces in alignment is that the payment for healthcare is moving from fee for service to capitated. That means the incentive is not to make people sick and have them run through the mill and be seeing them over and over and keep treating them and testing them. The incentive is the monetary incentive is to keep people healthy, to keep them out of the hospital, and so that is just, you can't overemphasize how important that is, because health systems will know, it's cheaper to keep people healthy, to get them together in groups, to learn to eat right, to learn to move their bodies, to learn stress reduction techniques, to learn how to support each other. All of those things will reduce healthcare costs and improve health. And with those incentives, I would think that systems will be investing in those things.
Actually, Bruce, that Jeff Geller, that's the model that his group uses out east, the capitated model. And so his whole day is just group medical visits. He doesn't do any individual patient appointments anymore. And some of the things he mentioned, just because people are asking about insurance, he'll do large groups, like let's say something on exercise, and maybe he'll let 20 or 25 people come to that group medical visit. And then he'll only bill for people who had a concern that he had to address that day. So he'll, have someone like a fitness instructor there that's leading the bulk of the group medical visit. But then at the beginning, they say anyone, having difficulties with their blood pressure, diabetes, and maybe there will be, 6 or 7 people in that out of that 25 who need his attention, and then he'll kind of pull them to the side. He bills for those people and not for the rest of the group. So there are creative ways that you can do it, but just for some of the people there is a little bit of a difference for some of the people who maybe aren't as familiar with group medical visits, between a class and a group medical visit. So for a group medical visit, we are charting on them, they're patients of UW Health. They have to have an applicable diagnosis for us to be able to do the billing piece. It's the billing and the facility fee that helps us to pay for our support staff. So, it's a little different than maybe classes in the community where people are paying for the class. So there are some differences there, but Jeff Geller kind of showed how you can sort of blur those lines a little bit, I think, so you can get creative.
While maintaining all integrity and following all rules, right? Yes.
Of course,
Yes. Any other comments or thoughts about group medical visits at UW Health?
So this is Ravi Hirakater. So great presentation, and I'm really impressed with the data that was provided. And in one way, moving forward, Bruce talked about how do you set up more studies like randomized control studies and stuff like that. And moving forward in a different direction, that would be to improve access. Group medical visits are a great opportunity to improve access, because I keep seeing the reports from administration saying that how many people are turned away. There's such a big backlog of patients to be seen. Group medical visits could be an answer. But again, for that, I've had the good fortune of attending Jeff Geller's a couple of workshops on group medical visits. And I'm really impressed with the way how he does it. He does over 80% of his visits are all group medical visits. And so we could move beyond wellness related issues into chronic disease management. For example, I do a lot of consults on inflammatory bowel disease. And could do group medical visits for inflammatory bowel disease. So we could, one of the important benefits that Sarah mentioned was the benefit from the group. Each person benefits from the group, and there's camaraderie, there's learning from each other, and that would be a great opportunity for IBD group to learn from each other how they manage their problems and stuff like that. So, maybe I'm thinking way too far ahead, or it could be very ambitious. One thing is billing needs to be on the same page. And maybe one of the billing people higher up could be invited to one of these group medical visits. And that could give them an insight of what happens in these visits and see for themselves what is happening during these visits, and maybe more support from the UW administration to support these group medical visits to improve access. Yes, hiring more people, building more facilities will take a long time, but in the meantime, we could improve access through group medical visits. So I'd like to, see what Bruce has to say. And by the way, this is, I really commend your efforts on doing so many group medical visits on different fronts.
Ravi, I'll send you, I did just meet with coding because we were billing all of our GMVs based on time, which were pretty much all level 2s. And they reviewed quite a few, and most of them we can be billing level 3s or maybe even level 4. I'm sorry that I didn't send you that information. I think I sent it to primarily to the providers who are doing GMVs through the Center for Wellness, but I will send that out to you later today so that you can see it. I did send 4 out of 7 of my, I just taught kitchen wisdom. I sent them back to the coders because I want to make sure that we're doing it correctly. And I had 1 correct with a level 3, 2 they bumped back down to a level 2, and 1 they did to a level 4. So it is kind of a learning process. I'm going to keep having them review a few random charts from every GMV that runs over the next year, so we make sure we're following all the rules. But we did meet with them, and they were actually quite receptive, which was a little different than maybe how things were a year or 2 ago. So I'll definitely send that to you. And I don't think you're too far in the future as far as doing these for specific health conditions. I think Sarah Suing might be working with some of the dietitians around maybe offering one for diabetes. Sorry if I'm speaking out of turn, Sarah, but we are like kind of looking at ones that are more specific for chronic health problems. So go for it for IBD. Jeff Geller said their most popular ones were OMT and acupuncture too. So that's the other one I've had in mind is OMT could be a great one since there's such a backlog for that.
And we do have Mike Williams, who's one of our faculty, is doing a group medical acupuncture group medical visit where it's battlefield acupuncture, needles are placed, and then he uses that time to talk about a whole health topic. I want to speak. Kate mentioned group medical visits for folks on dialysis could be very impactful. Well, holy buckets, yeah, you've got some people sitting there for quite a long period of time. What a great way to use that time. And when, Kate, your question about what does it take to propose or launch a group medical visit, I'd love to acknowledge Alyssa Bobo here and Diane Scherschel and the incredible amount of work that they do in the background to get this all going. And I know, Alyssa, you've been doing a tremendous amount with very little support staff. And please know that every conversation that I have had with anybody that touches group medical visits has been incredibly grateful and in awe of the work that you do to support everyone. So thank you. And Diane always in the background working on to make all of this happen and support Alyssa too. See, the chat's going to fill up now with Alyssa love. So another way that you hold us and we'll hold you too. And then in terms of what does it take to propose or launch a group medical visit, Lisa Simpson is actually our group medical visit lead in the Osher Center. And she's a resource. I'm volunteering her, but she's a resource for anyone in our system really that's interested in learning about group medical visits and how to put it together. Our philosophy has been that if you do a group medical visit with the Center for Wellness in the Osher Center, sort of if you're in our kitchen, you use our recipe, which is sort of that whole health model. But if you want to take some skills or learn some things to take group medical visits to other spaces, we're happy to help do that too. We believe in this model of care. We believe in bringing people together and shared learning. And so the Osher Center very much desires to be a resource to any folks that want to do that, both for the wellness, I think, of the people we serve, but also like, you know, some of the things that Sarah and Bruce mentioned about provider satisfaction and what that means. You know, it's a different way to use our skill set. And it's, you know, we're always looking for ways to make sure that our work stays fresh and renewing rather than, you know, that little bit burnout word that we talk about too. It's a way to use our skills in a different way.